yesterday, actually, I stopped at some of the important malignant tumors. The most important malignant tumors of the bone are the osteogenic sarcoma, and it's the commonest malignant tumor, the osteogenic sarcoma, which is the bone forming tumor. Then comes the chondrosarcoma, which is cartilage forming, which happens in the adult, especially in the 4th to 5th decade. Then there are two other important tumors which is of unknown origin. One is Ewing sarcoma and another one is giant cell tumor. These two are very important tumors. So yesterday I didn't want to hurry up. So all these 4 tumors, starting from osteogenic sarcoma, chondrosarcoma, Ewing sarcoma as well as giant cell tumor, will ask you as a short notes, and you will come across one of these tumors in your clinical life. This was a picture I stopped yesterday. This is a picture of fibrous dysplasia, which is a benign tumor. And here you are seeing this pink material is the osteoid that is formed, which forms different shapes like a Chinese letters, the cuneiform shapes. But the thing is, this is not really a complete osteoid. It's a developmental abnormality, or that is why it's called as dysplasia, fibrous dysplasia. Here, the bone osteoid, that pink material, is lined by spindle cells. So if you notice in the background, you're all seeing spindle cells. Okay, so this is a benign tumor. It can be involving one bone, or it can involve multiple bones. So coming to the most important tumor, that is Ewing sarcoma, which is also called as PNET. So now, earlier we used to differentiate Ewing sarcoma and PNET as 2 different categories. But now we know that both this Ewing sarcoma PNET belong to the similar category, because both share an identical translocation deficit, that is translocation 11 to 22. So this translocation is, you have to remember, because many times we ask objective question, what is a translocation that happens in Ewing sarcoma? So it is translocation 11 to 22, and it forms under the category of malignant small round cell tumor of the bone and soft tissue with a neural phenotype. Now just to recall, if you remember, there are so many small round cell tumors that occur in the pediatric age group. For example, from the kidney, if you remember, we taught you about nephroblastoma or Wilms tumor. Some endocrine, for example, from adrenal gland, you can get something called as neuroblastoma, which is also a small round cell tumor. You can get a medulloblastoma, which is a small round cell tumor from the central nervous system. So these are the tumors which are small round cell tumor. Like you have retinoblastoma, which happens from the retina, which you have learnt due to RB gene loss of retinoblastoma gene, which we taught you in the neoplasia chapter. So sometimes we may just ask you about malignant small round cell tumors of the pediatric age group. Then you should be able to write at least the predominant small round cell tumors happen in the children. So one from the kidney, that is Wilms tumor, one from the adrenal gland, that is neuroblastoma. Then you have Ewing sarcoma, which happens from the bone and soft tissue. And when you learned central nervous system, we'll also teach you about medulloblastoma, which is a blastoma which is happening from the central nervous system, and from the eye you have retinoblastoma. So here the bone tumor happens between the age group 10 to 15 years. If you recall, I said this tumor happens from the diaphysis. So we classified tumors as tumor arising from the epiphysis, tumors arising from the metaphysis, and tumors arising from the diaphysis. Now, osteogenic sarcoma happens from the metaphysis, okay, whereas Ewing sarcoma happens from the diaphysis. When we taught about, when I teach you about giant cell tumor, you realize this is a tumor which arises from the epiphysis. This is another way to remember, okay. So here the tumor involves the medullary cavity, and then it invades the cortex and the periosteum, and finally forms a soft tissue mass. Now this is how it looks. Starts as a diaphyseal tumor in the medullary cavity, and as you can notice, the red mark shows there is a soft tissue swelling. Now this is how it looks. You can see, if you age in diagnosis, it ranges from between, the peak is at the age 15 years. So it ranges between 10 to 20 years. You can see maximum cases happen during this age group. And you can see, just like any other small round cell tumor, the tumor cells are arranged in the form of rosette. Rosette means like flower shaped. Okay, you are seeing some pink material in the center of this flower like arrangement of the cells, which we call rosettes. So you will see rosettes in most of the small round cell tumor. Neuroblastoma, you will see rosettes. Retinoblastoma, you will see rosettes. Medulloblastoma, you will see rosettes. So here also they are small cells and they form rosettes. This is a typical picture of Ewing sarcoma. So grossly, how does it look? It forms a grey-white tumor. There will be large areas of hemorrhage and necrosis. So it is a malignant tumor, straightforward. Okay, and then there are small round cells which are uniform, scant cytoplasm, and they form what we call as Homer-Wright rosettes. Okay, now you will hear this terminology again and again because we use this terminology for neuroblastoma as well as medulloblastoma and retinoblastoma. So all these tumors will show Homer-Wright rosettes. That pink material, which looks like a neural material, is the center of these rosettes. And all those rosettes which have this neuropill-like material in the center, we call it as Homer-Wright rosettes. So what do you see in the X-ray? X-ray, again, there will be a destructive lytic lesion with permeative margins, because margins is not circumscribed margin. It's a malignant tumor, so it has margins which is irregular and it is permeative. And the reactive bone that is formed, it forms multiple layers. So it will form what we call as onion skin fashion. You know, you will see multiple layers of the osteosclerotic bone. It's not very clear in that particular X-ray picture. I think this is not, this is the next one. Here you are seeing another tumor which is in the bone, forming osteolytic lesion again. It looks more or less well circumscribed. So the first one, for example, it is in the lower end of the tibia, and you can see it is in the epiphysis, and it is quite well circumscribed. And if you see the center of the tumor in the right side picture, it forms sort of soap bubble like appearance. And there's a below picture we are seeing in the phalanx, similarly showing a osteolytic lesion. So this is a classical picture of X-ray in giant cell tumor. So giant cell tumor, they form very large red-brown tumor with cystic changes. Okay. So if you remember the classification, we classified giant cell tumor both as in the benign as well as the malignant, because these tumors can range from benign to malignant as far as their behavior is concerned. So we call it as potentially malignant. Okay. So we cannot straightaway say that this is benign. Okay. It is potentially malignant tumor. And what is the microscopy? You will see again round to oval cells which grow in syncytium, and what is most important is the presence of scattered osteoclast like giant cells having 100 or more nuclei. So there will be a uniform arrangement of osteoclastic giant cells in a background of these small round oval cells. Now many times we ask the questions, which are the malignant cells here, whether the round oval cells are the malignant cells or the giant cells are the malignant cells. Actually it is a round oval cells in the background, they are the actually tumor cells. Okay, osteoclastic giant cells are considered to be a reactive population of cells. Okay, and these round to oval cells will show a lot of frequent mitosis, and based on how much mitosis and based on if there is any metastasis, we decide this tumor is malignant. Okay, now X-ray, as I said, large lytic, eccentric, and cortex will be destroyed, and tumor can extend into the soft tissue. See, irrespective of whether tumor is benign or malignant, there is a tendency for the tumor to expand so much that the bone becomes almost, the cortex becomes almost eggshell-like. For example, in this tumor on the right side, in the metaphalanx, you can see the tumor is expanded so much that the cortex has become so thinned out, becomes eggshell-like, and then again expand into the soft tissue. So in such a tumor, you cannot actually save the bone. You may have to remove that particular or excise that bone completely. Okay. So this is the thing about, because it is eccentric and it can cause complete destruction of the cortex, extending into the soft tissue. And still, when it is part of soft tissue, you may still see a thin shell of reactive bone covering it. So this is how the tumor looks, lot of osteoclastic giant cells. You can see these giant cells, and that is how we diagnose this particular condition, uniformly arranged in a background of these round to oval cells. Okay, so this particular slide will show in the exam also. So you have to learn thoroughly because we will give you in the practical exam. So you should be able to draw that picture. So this is how it looks. In any view, you will see more than 25 nucleus. Considered to be more than 100 nucleus in a cell, the osteoclastic giant cells of the giant cell tumor. And you can, if you count, you may at least see 20 to 25 nucleus at a time. So large number of multinucleate osteoclast type giant cells. So it is also called as osteoclastoma. So it is considered locally aggressive, involves epiphysis and also the metaphysis. Main site is around the knee and patient may come with fracture. And age group, you have to remember, this is 20 to 40 years. So less than 20 years, Ewing sarcoma. Less than 20 years, also osteogenesis sarcoma. Between 20 to 40 years, you get giant cell tumor, and above 40 years, you get chondrosarcoma, and above 60 years, you get secondary type of osteogenesis sarcoma. So that is about the tumors. Then we have already completed the inflammation or infections of the bone. Now we have completed the bone tumors. Next important thing is to know a little bit about disorders of the bone growth and development. There are so many defects in the bone. A person can be born with certain dysplastic bone disorders. For example, one is achondroplasia, where the bone development is hindered and patient basically will be born as a dwarf. Okay. Then there is osteogenesis imperfecta, which is again related to, it's a group of genetic disorder where there is defective collagen type 1 synthesis. If you remember, the bone has type 1 collagen, which gives the matrix of the bone. Okay, and in these patients there is defect in the synthesis of collagen type 1. Based on what is the genetic defect, osteogenesis imperfecta can be many different subtypes. Okay, so this is osteogenesis imperfecta. You just have to remember it is defect in the type 1 collagen synthesis. Then we have rare disorder called as osteopetrosis. Petra stands for stone. That means the bone becomes like stone type, and it's also called as marble bone disease. Okay, so this is also a genetic defect where there is osteosclerosis to the extent that the bone becomes so hard that the medullary cavity almost disappears, and though it is stone like, but it is still can undergo fracture. That is a thing. So it is heavily mineralized, that is why there is osteosclerosis, but the thing is the bone can fracture. So the other name for osteopetrosis is marble bone disease, whereas osteogenesis imperfecta is called as brittle bone disease. In both there is a risk of fracture. Now next important thing is the metabolic and endocrine bone diseases. You know, the metabolism of bone requires calcium, phosphates, hormones like parathormone and vitamin D. So all these, and vitamin C. So all this can result in any defect in any of the metabolic factors can result in certain disease. And the most important thing which I am going to discuss is osteoporosis, hyperparathyroidism and renal osteodystrophy. But the thing is, all those hormonal defects may be due to thyroid dysfunction, pituitary dysfunction can also cause defective bone disease, and vitamin C deficiency, which causes scurvy, also involves the bone, and the vitamin D deficiency, especially in children, causes rickets, and in adults causes osteomalacia. In these, there is problem with mineralization of the bone because vitamin D is required for calcium deposition within the bone, and if that is defective, there is defective mineralization. So the most important disease here is the osteoporosis. Almost 30 to 40% of the population suffers osteoporosis, and we may come with a fracture of the bone at any time in life. So what is osteoporosis? Basically it means there is reduction in the bone mass, okay, or reduction of bone tissue, and it involves multiple bones, and because there is reduction of the bone mass, there is a risk of fracture. And where normally fracture happens? Mainly in the distal radius, in the neck of the femur, and also compression fracture of the vertebral bodies. Who are the susceptible people? It happens mainly in the postmenopausal women and elderly. It's more common in women compared to the men. Okay, it can be primary and secondary. Primary is the one which happens with the postmenopausal and senile one. Secondary is due to disuse. For example, some person is not using due to certain chronic disorder, or after a fracture, the bone is not utilized at all, the muscle is not utilized. In such people, there can be osteoporosis. Secondary also can be people who are going to space, they are against the gravity. So those people also, the muscles are not utilized. In those people also you can see osteoporosis. These are called as secondary. But the most important one is the primary, which is idiopathic or evolutional type. What is the main pathogenesis of osteoporosis? That is basically excessive osteoclastic resorption versus the slow bone formation. As the person ages, the ability to form the bone or the osteoblastic activity reduces, whereas the ability to resorb the bone, which is done by osteoclast, becomes excessive. So the ratio is tilted here. So more resorption happens than formation. So lot depends on who are susceptible for osteoporosis. Lot depends on what is the peak bone mass during your adult life. Okay. Now peak bone mass is reached as soon as a person reaches adolescent age. Okay. Now what decides the peak bone mass? Of course, genetic factors, the where you are born, the ethnicity, whether white versus black. For example, black people have more peak bone mass compared to the white. So there are a lot of genetic factors which decides peak bone mass, but there are a lot of environmental factors also which decides peak bone mass. Person whose nutrition is very good, vitamin D and the intake of calcium is very good during growing age will have good peak bone mass. Similarly, physical activity. Person who is totally sedentary, the peak bone mass will not be that good. Whereas person who is active and does a lot of athletic activity during growing years, their peak bone mass is very high. Now, if peak bone mass is good, then the chances of osteoporosis in the later age is less. If peak bone mass is already less, then chances of developing osteoporosis in later life is high. Okay. Now, in addition to peak bone mass, there are certain things which adds on as the person ages. So one is the aging, and second thing is in women it's also related to menopause. What are the problems due to aging? Aging because the replicative activity of the osteoprogenital cells, that itself gets reduced. Now from the osteoprogenital cells comes the osteoblast, and these osteoblasts also will have reduced synthetic activity as a person ages. And there is biological activity of the growth factors which is present in the matrix, that also reduces as a person ages. And one another thing is, as a person ages, the physical activity also is less. So these are the factors why the tilting towards bone resorption happens than bone formation, because throughout the life there is always a change in the bone forming unit. A bone forming unit will have matrix, the osteoblast and the osteoclast. Now osteoblastic activity and osteoclastic activity is always balanced. So if the bone is lost for some reason, the osteoblastic activity reforms that bone. Okay. So but as the person ages, there is a tilt in this and there is more of resorption than the formation. Similarly, menopause also adds to the burden. One is decreased serum estrogen, because estrogen is very important for the osteoclastic and osteoblastic activity to maintain the balance. So in addition, there is increased interleukin 1, interleukin 6 and TNF factors which add on to the activity of osteoclast, and there is increased expression of rank and rank L, and which all leads to increased osteoclastic activity. Okay, rank stands for the receptor associated neural factor kappa. Okay, so this receptor is present on the osteoclast and the ligand is present on the osteoblast. Now the activity of the rank depends on the balance between the rank and the rank L. Okay. Now rank activity actually causes increased osteoclastic activity, making the osteoclast to cause the resorption. Okay. So this is how the vertebral, the left side shows the vertebral body in the normal, but when osteoporosis happens, as you can see, there's a compression fracture, and the bony trabeculae, if you notice here, it is quite thin normally and becomes very thick, but this, if you notice the center it has become compressed. So that is called as compression fracture. This is what happens when the bone mass is reduced. This is another example to show healthy bone versus bone with osteoporosis. So what is primary osteoporosis? As I said, genetic factors, the gender, the women are more prone for osteoporosis compared to the men. Reduced physical activity. As you know, the physical activity is necessary for the peak bone, but as the person ages, the physical activity is reduced, and that adds to the burden of osteoporosis. Deficiency of hormones, not just the estrogen, even the testosterone. Deficiency of estrogen and testosterone will cause, it also causes primary osteoporosis. Then, in addition, deficiency of calcium, hyperparathyroidism, vitamin D deficiency, and the local factors. If you are not utilizing the bone for whatever reason, then also there is risk of primary osteoporosis. These are all the risk factors for primary osteoporosis. Secondary osteoporosis, mainly related to people with immobilization due to any reason, maybe due to chronic disease, and also anemia and starvation. Basically, factors which causes nutritional deficiency. Microscopically, what do you see? In the active phase of osteoporosis, there you can see a lot of osteoclastic activity, and you will see number of osteoclasts also increased. But as it reaches inactive phase, the osteoclast numbers also reduced and the osteoids become very narrow. So that is about osteoporosis. Then about hyperparathyroidism. Now, hyperparathyroidism causes increased osteoclastic resorption. And because of increased osteoclastic resorption, there is loss of bone, and also there will be inflammation causing osteitis and fibrosis as because of the reparative process of the inflammation, and cystic change. So when all these three things happen together, you call it as osteitis fibrosa cystica. Which are the bones that is involved? Mainly in the long bones. And what happens to the bones? There will be rarefaction. Basically, osteoclastic activity is increased linearly, and there will be a formation of rarefaction in the medulla of the bone, and this results in increased inflammatory reaction and some amount of bone vessels. Because there is a rarefaction, there will be hemorrhage into the area, which results in formation of hemosiderin laden macrophages, because hemorrhage leads to reactive process there causing inflammation, and macrophage comes in there trying to remove the blood components, resulting in formation of hemosiderin laden macrophages and causing a cystic change. Okay, and because of the color change and this tumorous lesion that is formed within the medulla is called as brown tumor. So you can see multiple brown tumors forming in the long bones in case of hyperparathyroidism. So two things are happening. One is increased bone resorption, and second is demineralization. Okay, so bone marrow undergoes fibrosis, hemorrhage, and because of the microfracture leads to cyst formation. And hemosiderin laden macrophages are formed because of the hemorrhage, and foreign body giant cells in the form of multinucleated giant cells also come in. So that the whole picture now becomes brownish in color and becomes tumorous. That's why we call it as brown tumor. So main pathogenesis is because of the demineralization of the bone and increased bone resorption. Okay, and because of the demineralization and bone resorption, the bone becomes weak. There will be microfracture, and because of the microfracture there will be hemorrhage, and because of the hemorrhage there is inflammation and there is fibrosis, and that leads to formation of cyst and collection of hemosiderin laden macrophages as well as multinucleated giant cells, and the thing becomes brown tumor. So sometimes we ask, where do you see, in which condition you see brown tumor? So you should say due to hyperparathyroidism. Many things can cause hyperparathyroidism. It could be primary or it could be secondary. Now this is how the hyperparathyroidism bone looks like. This is a brown tumor. You can see in the center of this particular bone there is lot of cysts like spaces filled with brownish blood colored substance. That is nothing but the hemorrhage which is organized. So this is called as brown tumor, okay, and specifically seen in hyperparathyroidism. Last thing you have to know is renal osteodystrophy, specifically seen in patients who have chronic renal failure or people who are on dialysis therapy. So what happens when there is renal failure? First thing is there is hypocalcemia, and second thing is there is hyperphosphatemia. That is, the phosphaturia doesn't happen, so the amount of phosphates in the blood increases, okay, and there is the calcium is lost. That is why there is hypocalcemia. So calcium level reduces and phosphate level increases, and whenever the calcium level is reduced, there is stimulation of the parathyroid gland to produce parathormone, because the function of parathormone is to make sure that there is enough calcium in the blood. So that will lead to bone resorption, because one of the source for the calcium is the bone. So bone resorption happens and increased metabolism in the GI tract happens to absorb more calcium, okay. So this is a way by which the parathormone tries to increase the calcium. So in the process what happens, the bone becomes thinner. As I said, all the things that happen with hyperparathyroidism will happen in a patient with renal failure, because this is secondary hyperparathyroidism. At the same time, because of hypocalcemia, there is all the features, because the active factor of vitamin D happens from the kidney. So if the kidney is failed, even if the person has vitamin D, it will not become the active form, okay. So because there is no active form of vitamin D, there is again calcium deficiency, and that results in osteomalacia like features, okay. So vitamin D deficiency causes demineralization of the bone, causing osteomalacia, and osteitis fibrosa happens because there is increased parathyroid hormone. Both adds to the damage. One is causing demineralization, another one is causing osteitis fibrosa by increasing the osteoclastic resorption. So based on what is more, sometimes you may get pure osteomalacia like features where the bone is not mineralized, or you may get pure osteitis fibrosa like features where there is action due to hyperparathyroidism. And in case of children, if the children has renal failure, they will develop renal rickets because their bone is not formed yet. So they develop more features of rickets. It depends on what the growing bone gets involved, okay, in case of rickets, whereas in osteomalacia, it involves mainly the pelvic bones, okay. So in addition, there is a risk of metastatic calcification. So these are the things which happens with renal osteodystrophy. So next important thing is the Paget's disease, which is again a cause of Paget's disease not known. It was first defined by a person called Sir James Paget. It's named after this person. That's why it's called as Paget's disease. As early as 1877, the first time this disease was recognized. Now, we do not know what causes this particular disease. It's more common in the Western countries. We do not see much in India. Especially happens with people who are above 50 years of age. What happens here is the bone undergoes alternative osteolytic and osteosclerotic activity. There will be first osteolysis followed by osteosclerosis, again osteolysis, osteosclerosis. It goes on like this, and etiology is not known. It can involve one bone when we call it as monostotic, or it can involve multiple bones when we call it as polystotic. And the risk is patient may come with fracture or sometimes deformity. One risk is Paget's disease is that these people can develop osteogenic sarcoma. So when we discuss secondary osteogenic sarcoma, we said one of the cause for secondary osteogenic sarcoma is Paget's disease. Okay. So what do you see? Because of the alternative osteolytic activity and osteosclerotic activity, there is a form of mosaic pattern that happens. Okay. Because there is osteolysis and then becomes osteosclerosis, and then again osteolysis. So it forms a pattern, okay? But that is only in the initial stages. In the later stages, osteosclerosis takes over and bone becomes very compact with poor mineralization. So the bone is compact, though there is sclerosis, bone is weak. That's why still can undergo fracture. So there are various stages here. The first stage is the osteolytic phase. The activity with the osteoclast is more. As you can see, the first part of the upper end of the bone, you can see the osteolysis is more, and the bone which is yellowish in color or slight gray in color is thinned out. Okay, the reddish portion is the lytic portion. So the medullary cavity is expanded, cortex has become very thinned out. This is the initial stage. In the mixed phase, what happens? There is osteosclerosis, which is more than the osteolysis. So you can see the central lytic portion has reduced and the sclerotic portion has increased. Then the later part, you can see down portion, the medullary cavity has become very thinned out and the bone, the grayish color, has become very thick. So this is what happens with later stages. So in the last portion, you can see it is giving the complete mosaic pattern. That is how it looks in the latest stage. So this is how the HND looks like. You can see what I mean by mosaic pattern. Because of the layers of bones are formed, it forms irregular lines. Normal lamellar bone, if you remember, they are parallelly arranged. The lines are arranged parallelly. But here is what happening. You are seeing irregular mosaic-like pattern because of this activity. In the later part, you are not seeing osteoclast anymore. You can see very few osteocytes inside the cells. Those nucleus which you are seeing in those tiny spaces, that has reduced so much. So that is the Paget's disease. So that comes to the ends of the bone diseases. You have to little bit know about pathology of the joints. Just as I said, infection can affect the bone. Most of the time, the pyogenic as well as tuberculous osteomyelitis can easily spread to the joints, and in that case, patient will develop suppurative arthritis. Okay, that means pus gets accumulated within the joint space. Same thing can happen with the tuberculosis, because in tuberculous osteomyelitis, the tuberculosis spreads into the joints and causes tuberculous arthritis. So in this case, you will see caseous material within the joint fluid. Okay. In addition, it causes inflammation of the synovium, which forms the covering for the joint space. But apart from this infectious arthritis, we can also get other arthritis which are much more common. Okay. The one is gouty arthritis, which is related to uric acid metabolism. Then there is rheumatoid arthritis, which is immune-mediated arthritis, and then there is osteoarthritis, which is age-related osteoarthritis. Okay, these are the three different inflammatory conditions of the joints, which is not due to infections. Okay, the gouty arthritis, the rheumatoid arthritis, osteoarthritis. There are many other, but these three are the important conditions which you have to know thoroughly. Now, this is how a patient comes. There is a swelling in the toe. Okay, very painful swelling. You can see the redness, and if you press, you will feel the tenderness also. So there's a swelling, and patients can really scream due to pain, and they will have sleeplessness due to this particular joint pain. Okay, so this is a very common presentation of gouty arthritis. This is how patient comes, typically happening in the toes. This is what happens actually. Patients have actually excessive uric acid in the blood, and this excessive uric acid gets deposited. You can see in the circle, you can see those needle-shaped crystals of uric acid which gets deposited in these joints. Because these joints have the temperature in these joint spaces is less than the actual body temperature. So it's the ideal temperature for the uric acid to get deposited. That is how they choose these joints to get deposited. And when uric acid as a foreign body gets deposited there, it causes inflammation. And all the pain is related to inflammation, because joint gets swollen and there will be fluid gets accumulated, and this uric acid causes foreign body giant cell reaction. This is how it happens. There are certain gout related food which because uric acid is related to purine metabolism. So excessive purines in the diet will lead to excessive production of uric acid and more pathological changes due to gout. Okay. Now, if you take a sample of synovial fluid from that particular joint, you will see under polarized microscopy these fluorescing crystals. Okay. So these are the crystals of uric acid, you can see. So what is the pathogenesis? As I already mentioned, main reason is hyperuricemia. Now, hyperuricemia could be primary, where you do not know where is the defect, or it could be secondary, that is of metabolic origin, or could be of renal origin. Okay, where uric acid is not excreted, so the amount of uric acid in the blood increases. So it could be excessive production or loss of excretion. Okay, so metabolic is only 10% where excessive production of uric acid happens. It can be due to patients with, say, excessive proliferation of the cells, like in leukemias. They have risk of developing increased uric acids. Okay, but most of the time it is related to renal gout. Why? Because here 90% is related to reduction of excretion of uric acid by the kidney. So 90% of the cases it is defect in the kidney. So the manifestation could be acute or chronic. Acute, I have shown that picture. Specifically, patient will have a swelling in the great toe because of the effusion of the joints in the great toe, and that result because of the deposition of the urate needles in the synovium. So that is the acute presentation. In the chronic presentation, there will be chronic tophaceous arthritis. These uric crystals, they finally crystallize there and form what we call as tophi. Okay, so tophi is the hallmark lesion of the gout. Okay, and because of the deposition of the tophi, there will be inflammation, and that causes arthritis, and it is chronic because it is progressive, and there will be formation of granulation tissue. In granulation tissue, here we call it as pannus, because joint is a space, and when the granulation tissue forms, it spans over the joint surface, and that granulation tissue we call it as pannus formation, and there is deposition of this tophi in the periarticular tissue. Tophi can also be seen in the soft tissue, and sometimes in case of renal lesions, you may see uric acid crystals getting deposited within the kidney parenchyma and resulting in renal condition called as urate nephropathy. Sometimes it can form stones, and then we call it as uric acid nephrolithiasis. These are the various manifestations of hyperuricemia. Okay, it can cause acute gouty arthritis, it can cause tophi in the soft tissue, tophi in the joint causing chronic tophaceous arthritis. It can cause renal lesion in the form of urate nephropathy causing renal failure in the later part, and it also can uric acid stones. This is how tophi looks, light pink fibrillary sort of material, and this fibrillariness is due to the presence of uric acid crystals. Okay, and you can see surrounding this pink material, you are seeing the inflammatory cells, and you may also see foreign body giant cells. These are the food which is good for people with the gout: more vegetables and fruits, less of meat. Okay, so that is about gouty arthritis. Then important condition is rheumatoid arthritis. Now this specifically involves symmetric peripheral joints, especially the small joints. This is a condition which happens mainly in females in 3rd to 4th decade, and this is an immune mediated disorder, but there is certain prevalence with the people who have HLA-DR4 and HLA-DR1. Okay, so that is the main genetic factor here. People with HLA-DR4 and HLA-DR1 polymorphism are more prone for developing rheumatoid arthritis. There's some amount of immunological factor because most of the patients are positive for what we call as rheumatoid factor. Okay, and this is an anti-IgG antibody, which is an anti-nuclear antibody. Okay, so it is seen in almost 80% of the patient, and that probably is the reason, though it is not very specific for rheumatoid arthritis, it can be seen in other conditions also. So, but then rheumatoid arthritis patients, almost 80% of the patient will show this particular thing. And rarely it is considered as maybe there is some role for some chronic infections. Now this is the pathogenesis. You can see those people who are genetically susceptible, or which means they have HLA-DR4 or HLA-DR1 in them, they will activate their T helper cells, which we call as CD4 T helper cells. And these CD4 helper cells will produce cytokines which can cause one side activation of B cells, producing lot of immune factors, especially the rheumatoid factor. And this rheumatoid factor goes and deposits in the joint as immune complex. And these immune complexes will cause inflammation and then resulting in formation of granulation tissue and pannus formation with the destruction of the bone, cartilage and fibrosis. On the other hand, these cytokines also will cause inflammatory cells to activate it and activate the fibroblast, chondrocytes and synovial cells, which releases enzymes like collagenase, stromatolysine, elastase, prostaglandins and other enzymes which will cause destruction of the bone and the cartilage in that particular area. Okay, and also there is proliferation of these cells like fibroblast proliferation resulting in fibrosis, and there is ankylosis, which means the joint surface is lost, it becomes narrowed. In addition, these CD4 T cells will activate the endothelial cells, and endothelial cells will result in expression of the adhesive molecules which causes accumulation of inflammatory cells. Basically what is happening here in nutshell is that those people who have got HLA-DR4 or DR1 who are genetically susceptible, they produce certain cytokines which will cause inflammation, which will cause immune mediation in the form of formation of rheumatoid factor, which forms immune complexes and which accumulates within the joint surfaces. So within the joint now what happens? There is formation of granulation tissue because of the inflammation. There is destruction of the bones because of the various enzymes that is produced like collagenase, stromatase and elastase, and then there is production of or formation of collagen and fibrosis. And we say ankylosis when the bone fluid is lost and the bone surfaces come together. So what are the joints involved in rheumatoid arthritis? Specifically, the joint involved are the small joints of the hand joints, and they are symmetrical. Patients typically say both the hands are involved. This is a very common condition. You will definitely see some cases in your postings. Okay. In addition, these people may also have what we call as rheumatoid nodules, which is specifically seen on the extensor surface of the elbow and fingers. So they will have certain soft tissue swelling on the elbows and the fingers. Microscopic features are non-specific. Basically what you see, you just see granulation tissue and synovial proliferation. So when synovium proliferates, they form villus-like structures. They form papillary structures. And what you see within these papillary structures, you will see a lot of inflammatory cells with the formation of lymphoid follicles. So in the clinical side, you will understand that rheumatoid arthritis need not be always in the age group 20 to 40 years. Sometimes it can happen in children when we call it as juvenile rheumatoid arthritis. Sometimes along with rheumatoid arthritis, patients will also present with splenomegaly, and then you call it as Felty's syndrome. There's another condition which is more associated with HLA-B27, more commonly seen in males, involving mainly the vertebral column, and it is called as ankylosing spondylitis, which is a variant of rheumatoid arthritis. Rheumatoid arthritis is more common in women, whereas ankylosing spondylitis is more common in men. This is how the joint looks like. This is the meaning of ankylosing. You can see in the smallest on the left side, you can see the enlarged picture of the bone space. You can see the bone space is reduced. It looks like they are touching each other. In the right side, you can see hardly any joint space is visible. The surfaces have come together. So when there is no, in these patients, they cannot bend their fingers anymore. In such cases, it becomes deforming. Okay. So microscopically, this is what happens. You can see the joint space. That orangish color is the pannus that is forming. Pannus first forms, the granulation tissue first forms in the joint periarticular region, and then it goes on to the articular surface, and when it forms on the articular surface, there is fibrosis, and when the fibrosis on the both surfaces happen, there is ankylosis. This is what happens. Microscopically, what you see, the synovium is expanded, synovium has become papillae-like structure, or what we say villi. So you are seeing in the middle picture, you are seeing multiple villi-like structure, and you can see in the right side picture, this villi, actually the lining, the cells which you are seeing are the synovial cells. Normally you will see 1-2 layers of synovial cells. Here you are seeing multiple layers of synovial cells, and below the synovial cells you are seeing granulation tissue. In granulation tissue, what do you see? Lot of lymphocytes and plasma cells and newly formed blood vessels, and sometimes with lymphoid follicles down below. So in the middle picture you can see multiple synovial villi, and which is lined by multiple layers of synovial cells, and underneath there is granulation tissue. If you look at the gross picture, you can see there is formation of articular surfaces. So that is what you see. On the leftmost corner, you can see the immune complexes initially gets deposited, and that will cause inflammatory reaction, bringing the neutrophils, lymphocytes, plasma cells and macrophages, and then they try to form granulation tissue because of the reparative process, and then slowly fibrosis sets in, and this granulation tissue, it will form over the surface. So in this joint space on the left side you can see the normal area, the normal the space, and on the right side you are seeing there is formation of pannus, and slowly as the pannus increases and fibrosis increases, it becomes ankylosis. The space is totally lost. Okay, so then they cannot bend their joint anymore. It becomes very stiff. This is what happens in rheumatoid arthritis. Now similar thing happens due to aging, due to degeneration in osteoarthritis. Here it is not due to immunity, it is due to aging, because as the person ages, there is always minor wear and tear over the joint surface. Okay, so this specifically involves the synovial joints. Okay, and degeneration starts in the synovial articular cartilage. If you notice, the synovial joints will have the articular cap on the bone head. Okay, so now this articular cap actually protects your joint. Okay, there is synovial fluid and there is articular cap which actually protects your joint. But the thing is, as you exercise and as person ages, there is minor wear and tear within the cartilage which cannot be replaced, and there will be minute fractures that happens in this cartilage due to injury and inflammation, and all this results in finally causing what we call as osteoarthritis. Specifically, the joint which involves are the major weight bearing joints like hip, knee and vertebral column. So what are the clinical features you see? Again, joint stiffness and diminished mobility. So the patient will have discomfort, pain, okay, and you will see what we call as Haberden nodules, especially in the smaller joints. Okay, they are nothing but the loose bodies. Loose bodies are nothing but the osteophytes, and the osteophytes in the vertebra can again cause compression of the cervical and lumbar nerve roots. Okay, so morphologically what happens actually, pathogenesis is, this cartilage normally gives a protective layer. Okay, but as the person ages, there is progressive loss of some amount of cartilage. Each time, due to minor wear tear, there is loss of cartilage, and as the time passes, when the cartilage is lost, the subchondral bone gets exposed. Okay, and when the subchondral bone gets exposed, there is compression of the joint space, and this subchondral bone undergoes rarefaction. Okay, there's loss of bone in this particular area, causing microcyst, microfractures, and these small broken pieces, they become osteophytes or loose bodies. And now these loose bodies will be loosely, the word itself says it's loose in the joint space. So you get sometimes click like sound as the person gets up in the morning. The joints will be very stiff, and when he walks, he gives that complaint that he feels that a particular click sound, which is actually loose bodies. And these loose bodies, especially if it happens in the vertebral joints, then what happens? These loose bodies can compress the nerve roots, and patient will have severe pain due to that. Now these osteophytes and these loose bodies will also affect the synovium, causing synovial inflammation, joint effusions, and similar to what happened in the rheumatoid arthritis, the synovium undergoes hypertrophy in the form of villi or papillary hypertrophy. This is what happens. You can see number 3 is a normal cartilage cap. Okay, so you can see that white cartilage cap that is present. If you look at number 1 area, that cartilage cap is totally lost and subchondral bone is exposed, and this subchondral bone, when person walks, there will be more fracture within the subchondral bone, and number 2 shows actually a hemorrhage and cystic space forming within the subchondral bone. This is what happens, and a chip of bone from the subchondral area loosen up and it goes free to the joint space, and that causes damage and eventually stiffness of the joint. So basically in osteoarthritis, the disease is due to wear and tear and due to loss of cartilage. So that actually brings the end of this particular joints and bone chapter. Okay, so I'll end here. Thank you so much.